Okay, everyone, welcome back. We're just about to start the second session, and I'll let the chairs introduce themselves in a second. If you're remote, just to say we're going to start back with our next case in the next minute or so. So I'll leave it over to the chairs to introduce themselves in the second session. Thank you.
Go ahead.
So thank you. Can we invite Dr. Carrie McGay to present the case from Chelsea and Westminster Hospital, anterior to posterior pituitary dysfunction crossing the divide. So yes, something that diabetes insipidus we need to learn in Guildford to call properly.
Hello, good morning, everyone, and thank you for your time. So as you all probably know, the diabetes insipidus is changing its name, and now the formerly cranial diabetes insipidus is actually being renamed as vasopressor insufficiency, and nephrogenic diabetes insipidus is now being renamed as vasopressor resistance. The main driver for the change actually came after the unfortunate death of Mr. Kangarni, who was mistaken to have diabetes mellitus and very sadly was refused his desmopressin after his just normal hip operation. So we will make a concerted effort to use the new name throughout the presentation today. So as we all know, the de novo vasopressor insufficiency is actually extremely rare in patients with pituitary adenoma who have never had any kind of surgery or biopsy. And of course, this will raises the possibility of other differential diagnoses, including malignancy, infection, or inflammatory disease affecting the pituitary. So here we are going to present a case which actually initially presented with a cystic pituitary adenoma and subsequently developing vasopressor insufficiency. So the case was, she was a 24-year-old lady. She primarily presented to her GP with complaining of headache and a secondary amenorrhea. And she did not have any other symptoms, including galactorrhea or any visual field problem at that point. So through her investigations in the primary care, she did have the persistent hyperlactin at around 900 milliunits per liter. And she also was referred to neurology because of the headache and had a brain MRI, which did show a pituitary cyst. And following that, she had a pituitary MRI, which I will discuss in a few seconds. And of course, at that point, she was referred to the endocrinology at Chelsea and Westminster for further investigation. So on her first initial visit in the clinic, so she still had that ongoing secondary amenorrhea, but no galactorrhea, no visual field deficit as before. And she also mentioned about excessive thirst, but no polyuria or nocturia at this point. And through the investigations that we did, so she again had a persistent monomeric hyperprolactinemia with the prolactin around 896 milliunits per liter. And she also had a borderline secondary hypothyroidism, as we can see here. The rest of the pituitary function was otherwise normal. So in terms of the imaging, so as I said before, so she did have the first pituitary MRI in December 2020, which did demonstrated a T1 hyperintense cyst, mostly in keeping with the proteinaceous or hemorrhagic cyst, with some suprasellar component, and also had a significant displacement of the infundibolum. However, the infundibolum thickness was completely normal. So in this imaging, as you can see on the sagittal T1 sequence, we can see that. Oh yeah. Oh yes. So we can see that 17 millimeter hyperdense lesion, which is actually in the posterior aspect of the pituitary. And on the coronal T1 sequence, we are still seeing the same lesion, and we can see there is no optic chiasma involvement, and there is some, of course, significant supracellular extension, and we can the deviation of the infundibulum to the left side is actually more obvious on the post-contrast imaging, which I'll show in a second. So on the post-contrast imaging, as you can see, there is no enhancement of the lesion, and the infundibulum is quite very obviously deviated to the left, and it's more obvious on this imaging. So on the subsequent repeated pituitary MRI, so as you can see here, so she did have a very significant reduction in the size of the lesion, and which these MRIs first one was done in May 2020, and the second one is in January. And then, of course, these T1 hypersensitivity also resolve, which is most likely in keeping with the resolution of the pituitary apoplexy. So then we discussed all the imaging in our radiology MDT, and the outcome was more or less the same. That is, possibly this is a resolution of the pituitary apoplexy. And in terms of her clinical symptoms, so she actually started having the spontaneous monthly cycles, and we also could see the pituitary, the anterior pituitary function actually became quite normalized as well on the bloods. And yeah, and the prolactin become completely normal, and the thyroid function is also pretty much normal. The rest of them was normal previously as well. So on the further reviewing the clinic, as I mentioned earlier, so she did mention about the excessive thirst at the beginning, but I think she didn't take that much notice of this. So then when we questioned that in more detail, she actually mentioned she's actually having the polyuria, polydipsia, and also, of course, a nocturia, and she's passing up to 11 liter. And she also mentioned that she was out with a friend, and that's the time that she started thinking about it. That might not be a normal thing. So she was out with a friend and just carrying multiple bottles of water. And the friends told her that shouldn't be normal, and you are just drinking so much and like passing a lot of water. So you probably need to mention that to your next appointment to your clinicians. So, and then for that, of course, obvious reason, we did arrange the water deprivation test, which I have summarized in that table, as you can see. So during the test, she lost 1.8 kilogram in her weight, and she continued passing good volume of diluted urine, and also plasma osmolality increased to 304, and sodium also increased from 140 to 249. She, of course, urine then concentrated, not incompletely after the desmopressin administration, and increased from 192 to 505. But all of this together confirmed vasopressin insufficiency. And for that reason, of course, she was started on desmopressin nasal spray 1 puff twice a day. Then on the following reviews, actually her sodium dropped to 127 while she was on that desmopressin 1 puff twice a day. And that raised the question of the possibility of the resolution of the vasopressin insufficiency. So then we arranged the second water deprivation test. And this time she lost more than 3% of the weight. And of course, we stopped at that point. And then she also, the plasma osmolarity also increased to 312. And the sodium also increased from 146 millimole to 153 millimole. And this time urine actually did concentrated completely. And the urine osmolality went up from 180 to 771, which of course confirmed the ongoing vasopressin insufficiency. So, and then of course the advice that we gave her just to reduce the puff to 1 once a day. And of course, we are just clinically assess her in a further next follow-up. So in summary, so in terms of what led the hair to have the vasopressor insufficiency, when we did review all the serial imaging of the pituitaries and the biochemistry in the regional pituitary MDT, it was still felt that probably the main everything mainly in keeping with the resolution of a pituitary apoplexy, and there was an absence of the posterior pituitary bright spot in all previous imaging, and there was also no feature suggestive of inflammation on the imaging, and she did not have any kind of steroid treatment at any point which could have treated an inflammatory or undiagnosed inflammatory lesions. And considering the spontaneous reduction of the size of the lesion, malignancy also was not suspected. So what we could come up as a possible differential diagnosis, whether that was just the two separate incidental diagnoses, or whether the pituitary apoplexy caused the vasopressor insufficiency. So now I just open the case to the panel and just to see for any further thought on the differential diagnosis or any further management. We currently following her up in and repeating another MRI in 6 months' time, and we of course clinically assessing any kind of symptom like resolution of the vasopressor insufficiency as well.
Thank you very much. That was a very puzzling case. Any comments? Oh yeah.
Thank you. So the VI was a bit delayed, right? She didn't have the VI when you picked up the hemorrhagic lesion. It came on a bit late.
So I think she probably, so on the first clinical review, when she came to the clinic, she mentioned about excessive stress. At that point, she was asked to make a record and just let us know. But I don't think she really took it very seriously. But then she was out with friends and she was carrying all these multiple bottles of water. And the friend said, because she just wanted to keep hydrated because she was feeling very thirsty. And then the friend told her that shouldn't be normal. And of course, she's a 24-year-old with a young mentality. That might not be an issue, but of course there was an issue.
Yeah.
So I think she probably had it.
Probably had it. Logically thinking, the posterior pituitary would have suffered with hemorrhage and then got manifested after some time.
Any other comments from anyone?
There is. Very interesting case. Was there an autoimmune workup done, and have you considered a biopsy?
I don't think we have done the autoimmune, no. And biopsy, I don't think it was considered because I think it was just because of a very significant reduction in size. I think that we never consider, but Dr. Rankin.
Yeah.
Yeah.
Yeah, and also surgically, I don't think we would have offered any biopsy. It was almost resolving completely down, and so there was nothing to biopsy.
Yeah, I'll just repeat Alison Wren's point, which is that the patient has normal pituitary function, and if you biopsy it, you might affect that and make the patient hypopit. So that's an issue. It is interesting because it's an unusual outcome for apoplexy.
Yes, I mean, it did look like quite a clearly defined lesion, didn't it, rather than an inflammatory process, I guess. But
have we thought about lymphocytic hypophysitis?
I think because the infundibulum thickness was completely normal, I think pretty much allowed this.
It's going to end up as one of these cases that we never know the cause of the vasopressin insufficiency. Well done for using that. I like the title as well. Device, DIVI.
So I suppose we're saying that the manifestation of a posterior pituitary involvement is unusual for apoplexy, but not unheard of, in fairness. Is that what we're saying?
I think the comment is reasonable. Looking for other causes, if you have just vasopressin insufficiency by itself, is something that we usually do. And then there's a question here, is there a potential that VI will recover in the future?
I think we are definitely assessing in her follow-up. So we already have reduced the desmopressin to 1 puff per day, and we will definitely assess in the next follow-up. But yeah.
Okay, and there's a comment here from Brian DeCosta in Wakefield, who had a similar case that developed VI, and it all resolved later. We also felt it was apoplexy, and retrospectively may have been hypophysitis.
I wondered, I'm so sorry to pick on Emma for a minute, Emma Lynn, our neuroradiologist. I wondered just about the posterior lack of the posterior bright spot, and if you could just maybe talk to us about, because you commented in your presentation that it was absent, but I wondered if you could just talk to us for a minute about the significance of that, because my understanding, I think, is that you can have normal posterior pituitary function but not have a bright spot, but I might have got that wrong.
Thanks. Yeah, my understanding is that sometimes you don't visualize a posterior pituitary bright spot in, for example, patients as they get older with diabetes, in pregnancy, for example. So it is possible to have an absent posterior pituitary bright spot on imaging and for it to be asymptomatic.
So not pathological.
No.
Okay. Was there anything you wanted to say about that imaging, just about whether it looked inflammatory or anything, just from educating?
Yeah, so I don't personally think it looks inflammatory. It's a very well circumscribed process. It doesn't have the typical enhancement characteristics of an inflammatory lesion where you'd usually see avid generalized contrast enhancement, although it is possible to get a sort of rim enhancing central necrotic hypophysitis, rarely. Also, as mentioned, there's no involvement of the stalk, although you can have primarily anterior involvement in it, so it doesn't have to be involved, but it would be more typical. So it doesn't particularly look inflammatory. Also, both in cases of hypophysitis and an acute apoplexy, you might also see local reactive changes, for example, in the sphenoid sinus mucosal thickening, or some dural enhancement around the retroclival venous plexus and the planum, but we're not seeing any of that either. And so yeah, in this particular case, the imaging here is not particularly representative of either apoplexy radiologically or an inflammatory process.
Thank you. That was really clear. Thank you very much for that.
There's one comment. Can we just go to the first water deprivation test?
Yes.
So there's a comment here about the urine osmosis going up with time and whether we can wait. And I think I can answer that because if you look at the right-hand column, the osmolality was really quite high. And so it gets dangerous if you make someone very dehydrated, because the urine osmo, I agree it's going from 87 to 192, but you can see clearly that when you give them some vasopressin, it shoots up to over 500. So if you hadn't done that and carried on, the patient would have got more and more dehydrated, and the osmo would have gone up and up and up. So that's to answer the point there. And then it was repeated, and even then they had the same thing. I will just point out, interestingly, the plasma osmolality has a bit of a variance on it in that it should also be rising. It was 296, 296, 308, 304, which is, we've started doing sodiums, which seem to be a much better marker, although there isn't a cutoff that's defined yet. But it's not possible for the osmo to go up and down if they're not drinking anything. Question, how has the vasopressin helped her?
So she definitely, like in terms of the urine output, that has definitely worked. So it's definitely now, yes, it definitely has reduced the polyuria. And we also advise her to stick to like 2 to 2.5 liters of like daily fluid intake as well. But definitely has helped.
Thank you. And then there's a question about, obviously we're very worried about the pituitary. Will a PET be useful, a PET scan? I don't know if radiology wants to answer that.
Poor Emma. It's just that it's a good question, PET, because certainly in our MDTs recently, we've had a few patients who have popped up where they've had a PET for other reason that's then flagged an abnormality. So it sort of works in both directions. What are your thoughts about PET for the pituitary, Emma?
So unfortunately, I don't know because I'm not a nuclear medicine radiologist. My understanding is any inflammatory process could be avid on PET, as can macroadenomas. I don't think it's particularly helpful in taking differential diagnosis further, but beyond that, I can't really say, I'm afraid.
And remind me, on a PET, does the normal pituitary look hot, or is that a pathological abnormality? I can't remember either. Okay, thank you. So they're not very specific. A PET, I think, is the potential answer.
And there's one other question. How would you comment on the variability in the patient's DDAP requirements? The variability in the amount of DAP the patient needed, it changed, isn't it, as time went on?
So that's why when the sodium dropped to 127, so we thought that might be the possibility of the resolution of the vasopressin insufficiency. So that's why we did repeat the test and didn't confirmed that, and
Yeah.
we just reduced the dose of desmopressin nasal spray to 1 spray like a day, and we of course reassess that in the next her following follow-up.
Yeah.
But yeah.
Thank you. And there's just a comment. There's someone else had a similar case. It was very sensitive to low-dose vasopressin. So we have a few others.
Interesting. Thank you.
Thank you.
Thank you very much.
Thanks very much.
Thank you very
so
much.
let me invite Dr. Kanyada Koistambat talking about beyond pituitary gland.
Hi, good morning. So my name is Kanyada. I'm one of the ST5 endocrinology registrar here at Charing Cross Hospital. Thank you for the opportunity to present the case titled Beyond the Pituitary Gland. So we've got a 29-year-old man who presented with an acute vision loss affecting his left eye. He first presented to his optician, who then referred him as an emergency to his ophthalmologist. His ophthalmologist then arranged an urgent MRI brain. The thought at the time was, could this be a potential optic neuritis? So this is his MRI imaging. So we've got here a T1 weighted MRI. So to orient ourselves, this is his right orbit, this is his left orbit, and we've got the rectus muscle coming off. On this slide, you can see that there are two optic nerves converging, and where the optic chiasm should be on this image lies the lesion. Okay, so it was reported as the lesion being in the region of the optic nerve. If we look at the different views on the T2 weighted axial and coronal view, if we talk about the T2 weighted image first, you can see the middle cerebral artery coming in right here, and here you've got the midbrain. The lesion is here. You can see it's a mixed cystic and solid lesion. The solid component of the lesion appears to be iso-intense to the brain parenchyma, whereas the solid and cystic lesion seems to be of the same density of the CSF, which is seen on the coronal view. This is a lovely image of the T1 weighted sagittal view, and you can see right here, this is your brainstem structure. So you've got the midbrain, pons, and the medulla, the fourth ventricle, and the cerebellum right here. You can see that the lesion is centered around in the middle of the brain. The pituitary gland sits in the sella turcica, and nicely the infundibulum is separate. So the radiology report is such that the mass is separate from the pituitary gland and is suprasellar in nature, as highlighted right here. So based on the radiological findings at the time, the differential diagnoses were craniopharyngioma, dermoid cyst, epidermoid cyst, and a glioma, and also consideration for a germ cell tumor as well. The case was then referred urgently to neurosurgery and endocrinology through the Imperial Pituitary MDT. Because of the uncertain nature of the mass, neurosurgical team planned a biopsy of the mass, and endocrinology review was done to evaluate his pituitary profile. So when he was seen in the endocrinology clinic, he reports no symptoms of hypocortisolism, no symptoms of hypothyroidism, and no symptoms concerning of vasopressin insufficiency. However, he did report symptoms of low libido, lack of morning erections, lack of facial hair, and difficulty gaining muscle mass despite going to the gym regularly, which is in keeping with hypogonadism. On examination, he was quite tall, 188 centimeters, with a low BMI and a low muscle mass. He had quadrantenopia affecting the left inferior nasal region, and he appeared prepubescent with lack of facial hair and hair on his extremities. Testicular examination revealed prepubertal testes, which were confirmed later on testicular ultrasound. So on the right side, it measures 0.6 mils, and on the left side, measuring 0.8 mils, which is consistent with chronic hypogonadism. We then, on the subsequent day, arranged the 9 a.m. hormonal profile, and I'll go through each axis in turn. You can see that his free T4 is low with an inappropriately normal TSH, which is in keeping with secondary hypothyroidism. Similarly, his cortisol, 9 a.m. cortisol was 46. Now, this gentleman's not been on any steroids, and his ACTH is not raised, which is in keeping with secondary hypocortisolism. Testosterone was undetectable at 9 a.m. with an undetectable LH and FSH in keeping with secondary hypogonadism. He also has growth hormone deficiency and a raised prolactin, which we think is due to disconnection hyperprolactinemia. Because there was some query that this could be a germ cell tumor, we did a plasma serum tumor markers, which were both negative. So then we moved on to the left frontal temporal craniotomy, which Mr. Nair will kindly talk us through the video. So I'll just start the video.
So this is the intra. Working. Yeah.
This one's on actually, this one here, and I'll take that one.
Okay, what you see there is the intracranial view directly over the optic nerve. What I'm expressing is a swollen optic chiasm, just retracting the frontal lobe there. The carotid artery is the reddish one onto the left of that whitish structure. So I'm just pushing the brain away to expose that area. That chiasm looks swollen. Normally, it's not that swollen. So there was no area where I could biopsy from in that location. So I just had to look for other areas. Normally, I would expect the tumor to be under the optic chiasm, but preoperatively, there was a concern that this could be an optic glial tumor. You can move on to the next video. Next one. Yeah, so this is the biopsy. The optic nerve, optic chiasm is being pushed to one side, and below the optic chiasm, we encountered the mass, and there was a small incision on the mass, and there's a biopsy that's being taken with that forceps. And given that it was not really very clearly differentiated from the optic pathways, we didn't do any further debulking. It's just a biopsy from that region.
Perfect, thank you. So then intraoperatively, the patient was found to be polyuric. As before, the patient didn't complain of any symptoms suggestive of vasopressin insufficiency. The sodium has been normal throughout. So this is pre-op on induction. As we progress through the operation, you can see that the sodium started to rise slightly, slowly. And towards the end, that is his serum sodium and plasma and urine osmolality. So as an endocrinology registrar holding the bleep, we got an emergency call from the anesthetist asking what you would like to do next. So we've done a poll. So what would you like to do next? Whether you want to reassure, give 5% IV dextrose, normal saline, DDAVP, or call your consultant. Actually, I guess it's more than one answer.
Not everyone to vote, okay? Why not everyone vote? You got it. Yeah. Okay.
Yeah. No, I did it.
Yeah.
Perfect. So majority went for subcut DDAVP. Like I said, there's probably not one right answer. I'll just go back to see what we've done. So what we did next was, I guess we did two things. So we gave subcut desmopressin 1 microgram and continued IV 5% dextrose that the anesthetists have already commenced. We closely monitored his urine output and serum sodium. And once he started to eat and drink, his sodium denormalized with subcut desmopressin 1 microgram per day. We've got the histology findings right here. And I think Dr. John Martin is going to comment.
Come down, or do you want to do it from there? Okay, perfect.
Yeah, so what you can see in this case, it's a very classic appearance of germ cell tumor. So you can see in between these small cells, which are just normal reactive lymphocytes, there are these cells with very large nuclei and prominent nucleoli, which is an absolutely classic, already H&E appearance of a germ cell tumor. And then there is a very specific marker for germ cell tumor, for germinoma, called OCT34, which is a germline specific marker involved in inducing the pluripotency of the germline cells. And when the tumor cells are germ cells, they show this nuclear expression of the OCT34. And as in this case, typically the AFP, HCG markers are negative in serum, as it was in this case. We do a bunch of other markers to exclude additional germ cell components, such as from the yolk sac or teratomas, and none of that was present in this case, so a pure germinoma.
Lovely, thank you. So yes, so a decision was then made to start systemic chemotherapy, and he was transferred to the oncology ward under the germ cell team. So because this gentleman was only 29 years old, previously quite fit and well, and we were going to start systemic chemotherapy, there was some consideration with fertility preservation for this gentleman. We attempted to harvest sperm from his ejaculate, but unfortunately no sperm was present in the ejaculate. We thought about doing further attempts with sildenafil, but again, that was unsuccessful, and there was some consideration of microtesticular sperm extraction. But chemotherapy could not be delayed due to the nature of the lesion and the risk of further visual impairment. So we went ahead and gave him chemotherapy. So each chemotherapy consisted of 6 liters of fluid per day, which was given on a weekly basis. Now, that made the management of vasopressin insufficiency very difficult, requiring daily DDAVP dose adjustments according to the serum sodium and fluid balance. And because of the chemotherapy, patients feeling unwell, he had variable oral intake, so it's really difficult to manage using different formulation of DDAVP, switching between oral, intranasal, and subcutaneous. So where we are now, he's now completed chemotherapy. He's awaiting MRI, repeat MRI, and endocrinology clinic to reassess pituitary function. He remains on levothyroxine, prednisolone, testosterone, and DDAVP replacement until further review. So I guess some of the discussion points I wanted to highlight was, what are the fertility options in this case? Management of AVP deficiency in patients requiring large volume of fluid with variable oral intake, and when and how do we evaluate the hypothalamic pituitary function after completion of treatment? And I hope to have illustrate the MDT team working in this gentleman between oncology, neuroradiology, surgery, and endocrinology.
Thank you. Thank you. Beautiful presentation, I have to say, brilliantly presented. Wait for any comments or questions from the audience.
There's just a thing in the comment here. Is there any role of surgery to debulk the tumor before chemotherapy because it was so big?
Yeah, so germ cell tumors, often germinomas, sometimes we have a preoperative diagnosis based on several other radiological features, but sometimes it can be a surgical surprise. In many cases in the past, we often come across this diagnosis after the biopsy. And the decision to debulk Depends on where the location is. In tumors very close proximity to optic chiasm and critical structures, we don't tend to debulk. And also it's not needed in terms of tumor because they are eminently treatable with radiotherapy and chemotherapy. So we don't tend to debulk. But in some locations, it is not in close proximity to major structures, we might debulk. But I think they respond very well to the other medical management. So we don't tend to.
So what about radiotherapy?
The chemo and radiotherapy, yeah.
Okay. Not proton beam?
I think from a surgical point of view, we've learned that you can harm patients if you poke around in those territories and affect food intake and all kinds of other things that can in the long term. So we're much more cautious than we used to be.
Yeah, I think the diagnosis also wasn't very clear-cut preoperatively in this case. In fact, one of the diagnoses was given his age and the presentation, the location we thought could be a craniopharyngioma. But normally we would operate them through the nose endoscopically because there was a concern about his location in the optic chiasm. I thought it may be safer to do it cranially where I can have a full view of the optic nerves and structures around it. Ma?
Lisa.
Hi, I'm Lisa Yang from Imperial. I do remember this case, but maybe just remind us, on the initial imaging, what's the pituitary look like? Because why does he have pan-hyperpituitarism with what looks like quite a purely supercellular lesion that we decide in the end?
This is the first set of imaging. It's not a dedicated pituitary scan. It was done over at Northwick Park. The pituitary is separate. The infundibulum is also separate. The mass is clearly supracellular, but
I think we felt it was there were no hypothalamic factors. So it's quite interesting, isn't it? If you think about medical school in terms of your chain of command and hypothalamus and anteropituitary, he'd lost all his hypothalamic signals. So it's really interesting, isn't it, that you've got pan-hypopituitarism, but it's not pituitary failure. It's the hypothalamus isn't talking to the anteropituitary, which is, I think, presume the issue here.
He did not have any post-treatment scans yet. I thought may have had some scans by now, probably. Not yet? No. Okay.
Not yet, I don't think.
Yes, there was one hot off the press which hadn't changed despite everything, but there wasn't any oncology. He's waited to be seen by oncology, so we've paused the presentation because I didn't really feel like we knew what more to say about options if it hadn't really changed in size.
But generally, you find that the post-treatment scans are much remarkable in terms of the resolution of the whole thing.
There's one other thing here which is quite interesting. As she's misspelt VI, okay? As VI was picked up intraoperatively, was it a complication of surgical procedure?
Possibly, because you're moving around that stalk and potentially that manipulation would have precipitated it, even though he was at risk for that anyway from the tumor itself.
It's also possible that he was drinking lots of water beforehand. Once you nil by mouth, you then see it, but we don't know.
Well, we did look for that, didn't we? I mean, when we were prepping the case, we double checked all of that, and I think it looked as if because he had a very nice clerking that was normal, that being asked about was normal and his sodium was normal. So I suspect it probably was perioperative, but rather than pre-existing. Should we, because we've got time, it was such a lovely presentation, should we go back to the questions and see if we could answer them for a minute?
Yeah, that's exactly what I wanted to do because I was very curious about the question number 1. What are the fertility options in this case?
Let me give this to Robert
Open
Murray
question
from
to
Leeds.
everyone.
Robert Murray, Leeds. Do we know what chemotherapy he had? Do we know if he was at risk from it?
I think there were 3 agents. I can't remember exactly the names of the chemotherapy. I have to look it up.
Yeah. Cisplatin, etoposide, probably vincristine.
Cisplatin is etoposide.
Yeah, cisplatin is not too bad. Depends on the dose range, but if you don't mix cisplatin with an alkylating agent, it's usually okay. So if it was cisplatin, etoposide, not a problem, and vincristine is probably the other agent, then your likelihood of primary fertility is pretty close to zero. So you're really only then thinking that you're going to induce with radiotherapy hypoc, in which case you can treat them with gonadotrophins, can't you, afterwards, if you haven't got time. If you had time, you could do TZ, but trying to get a TZ up and get sperm, because I suspect he might have something on TZ. But to do that and then freeze something from TZ, because usually you'd want to use TZ hopefully straight away rather than freeze them. And
I think he was in a relationship at the time. I guess he's pre-pubertal. Would you then have to induce puberty before you can get something from his testes?
Yeah, but I think all that could be done later, couldn't it? We can add trophins after all of this is gone, as long as we've got chemo agents which aren't going to give us primary testicular failure.
Just a comment on another thing here from Anna Crown saying we're a bit stuck with fertility as he's got pre-pubertal testes on presentation. So that his prognosis is going to be very poor. And just one other comment, one question really, and that is, if his vision was not affected and the mass was smaller in size but a macro, would you still proceed with a biopsy based on the radiological findings?
So I think the diagnosis was uncertain. Even if there was no visual field deficit, then there's no urgency to try and do an emergency biopsy. But then if you have a concern that it could be a germ cell tumor, then you would want to biopsy before considering any further adjunctive treatment. But clearly he had a visual problem in this case. But normally, I think, normally you wouldn't expect in lesions in the supraocular space, germ cell tumors to cause a lot of deficit, but he had a significant visual field deficit, which I suspect was the involvement of the optic chiasm at that level.
There's a question here, do we think that CSF, AFP and HCG are sensitive enough?
Well, germ cell tumor, generally majority of them, but we've seen several cases where you don't get any positive markers at all. Anybody else?
I was just going to ask the same thing about CSF, but another thing, the ACTH was a bit higher than typical for secondary adrenal insufficiency. What are your thoughts on that?
Yes, I said the same to Kenyatta when we looked at the talk on Friday. I said, oh, I suppose it's still, because the cortisol was 47. So I suppose I said the same, and then Kenyatta reminded me that it was inappropriately normal. So that's what I kind of went for. But I hear you that it wasn't less than 10, was it, I guess? So, and then, yes, the point about CSF tumor markers is that if they're negative in serum, you can go to CSF next, which we didn't here because there was such a broad differential. But there are cases of germinomas, of germ cell tumors with negative tumor markers on CSF and serum. And I think partly the drive for tissue was because of, as Ramesh has said, there was a very broad differential and we were unsure what we were managing really. Oh, sorry. Oh, hang on 2 seconds, just because the people remotely can't hear you, sorry.
Thank you. No, just to emphasize that this specific germ cell tumor, germinoma, does not express AFP or HCG, so there is no chance it will be positive in blood or CSF. So if it has additional germ cell component like yolk sac, embryonal carcinoma, choriocarcinoma, then it will have a AFP, HCG pickup in the CSF or blood. But in this tumor, it by default should not show those markers.
Okay, that's very important.
That's really helpful.
No, not really. No.
Okay, thank you.
So if we move to the next case, the difficulties in managing AVP deficiency following pituitary apoplexy, and that would be presented by Dr. Benedict from Eastern North Hertfordshire NHS Trust.
A second, yeah.
Thank you for inviting me to present today. I'm one of the F1 doctors, Catherine, from Lister Hospital in Stevenage, and I'll be presenting on the difficulties in managing AVP deficiency following pituitary apoplexy. So to introduce the case, this is the case of a 79-year-old man who was previously fit and well. He presented with a 3-day history of severe retroorbital headache with visual impairment, right-sided weakness and reduced GCS. So these symptoms didn't all present at the same time. And he was initially seen by a neurologist who considered meningitis as the presentation. So he treated for meningitis with lumbar puncture and CT hairs. His past medical history includes hypertension, hypercholesterolemia, benign prostatic hypertrophy, cataracts and bradycardia awaiting a pacemaker. And this patient was independent prior to admission. And his medications are also shown on the screen. The pituitary apoplexy wasn't considered until a week into admission because of additional complications. So the patient had sepsis of unknown origin and also had norovirus. So when pituitary apoplexy was considered, the pituitary profile is shown fitted with biochemical hyperpituitarism, and an urgent MRI head was done, and that MRI showed a 20mm pituitary mass which enlarged and was causing a mild displacement of the optic chiasm, and also showed an acute left anterior thalamic infarct. So this slide shows the MRI, the pituitary, and that there was hemorrhage into a necrotic macroadenoma with infarction. And so the patient was transferred to Cambridge University Hospital. But because of the delay in diagnosis and the patient's current stroke, there was hesitation about the benefit of pituitary surgery. But on balance, he clinically improved. And so Adam Brooks accepted him for transsphenoidal pituitary surgery. And he was also reviewed by ophthalmology, who were unable to assess his visual acuity and his field accurately due to the patient being inattentive due to a fluctuating GCS of around 9 to 11. And so following endoscopic resection of the tumour, the patient was transferred to neuro ICU in Adam Brooks and monitored for his fluid and sodium balance. And this shows a limited summary from the transfer notes from Adam Brooks in Cambridge. And so in ICU, the patient was managed post-operatively with hormone replacement and also intermittent desmopressin. And we suspect that the patient had a triphasic response because initially he had AVP deficiency requiring desmopressin and then a possible SIADH. And this is because at one point the patient's sodium dropped to 121 and he had what they described as this funny tin. And then following that, he became polyuric again and then requiring desmopressin again. And then the Cambridge team attempted to withhold the DDAVP, but each time they withheld it, the sodium would climb and he'd become hypertonic. But then the patient was transferred to East and North Hertfordshire's ICU, and his urine output was monitored hourly. And if the urine output was greater than 300 milliliters for 2 consecutive hours, then he was given the DDAVP. When he was receiving regular DDAVP of 25 micrograms orally in ICU, he was not passing urine at all during the day. And then he'd regularly pass urine at 10 p.m. at night as shown for a couple of hours before being given the next dose. And his sodium also fell in ITU. And I believe that they were replacing his urine output, and that might have been what was driving this. And the patient's total cumulative urine output was around 2.5 to 3 liters a day. And so this graph shows the sodium levels when the patient was admitted to ITU. And these green arrows show where DDAVP was given at 25 micrograms of oral desmopressin. And the regimen of DDAVP administration led to, in this patient, hyponatremia. And so this diagram also reiterates that the patient would not pass urine during the day, and then he would pass a lot of urine. And so then he was given the DGAVP that caused him to stop passing urine. But then the effect of the DGAVP would run out and he'd pass a lot of urine. So therefore was given more DGAVP. And so as you can see, it's a vicious cycle. There's some questions for you to consider. Do you think this patient has AVP deficiency? I don't have a Mentimeter slide. And then based on that, what would you do next? So some options would be stop the DGAVP and monitor urine output and allow the patient to drink freely, or continue with the current plan and monitoring urine output and giving DGAVP if the urine output was greater than 300 milliliters per hour for 2 consecutive hours? Or would there be something else that you consider? So I can come back to that. So the sodium levels, so this slide shows the sodium levels on the endocrine ward. So the patient was transferred to endocrine, and here we changed the parameter of when we gave DGAVP. So instead of waiting for 2 hours, we waited for 4 hours. And for the first 4 days, he maintained a normal sodium and did not need any DGAVP. His weight was stable, around 63 kilograms, and his urine output was around 3 liters per day. But then on the 1st of August, he passed 5 liters of urine and his sodium increased to 147. So we gave 1 dose of DGAVP. But then his second sodium level, when we looked at the bloods, was actually normal. And this level had been taken prior to DGAVP being given that evening, suggesting the patient had already self-corrected their sodium level. And the patient wasn't given any further DGAVP during this admission in the endocrine ward. So just to mention copeptin, for those in the audience who aren't familiar, copeptin is analogous to C-peptide and insulin, and it's a fragment of the precursor AVP peptide. It's a sensitive and stable marker for AVP release and kind of a way of measuring AVP levels in the blood. So whilst the patient was on the endocrine ward in Lister, we had an email from Dr. Powelson at Adam Brooks, who'd measured the copeptin level of this patient while the patient was polyuric and hypernatremic. And the result was a level of 2.9 for the copeptin, whilst the patient's sodium was 154. And this high sodium should have stimulated the release of AVP. And so Newcastle quotes that copeptin less than 5 fits with the diagnosis of AVP deficiency. So this therefore fits with this patient having AVP deficiency. And so to kind of go back to this patient's AVP sensitivity, the dose of DGAVP doesn't change its effectiveness, but it changes the length of time that DGAVP works for. And there are reports that AVP sensitivity following AVP deficiency, a diagnosis. And this may be due to the upregulation of AVP receptors in the kidneys. So for our patient, DGAVP treatment led to hypernatremia, and this happened despite intensive monitoring on 2 different intensive care admissions. Our patient maintained his eunatremia, so normal sodium and volume status, without needing AVP replacement. And he had an intact thirst mechanism. So as a result, we educated the patient on drinking to his thirst, and we measured regular body weights daily for this patient. So as mentioned before in one of the previous cases, there's a case of a young man called Kane Gorney who sadly died due to his AVP deficiency being misdiagnosed. Really highlights why it's so important to kind of increase awareness and recognition of AVP deficiency amongst healthcare professionals. And also MDT involvement is crucial in diagnosing pituitary apoplexy, because there's a wide list of differentials for this headache presentation. And current guidelines on AVP deficiency don't address the group of patients who aren't requiring DGAVP treatment. And patient information leaflets are also not applicable to people taking DDAVP. So it's important to increase awareness in this group of patients who have AVP deficiency but aren't requiring DDAVP. So thank you very much.
Thank you very much. That was a very interesting case. Definitely lots of challenges. Is anyone to comment, make any comments?
When the patient came in with this right side weakness and the CT scan was normal, was he thrombolized? Do you know? With the stroke team?
I don't think so, no, because it was normal. They were looking for other causes of the.
And you could explain the hemorrhage after that, but was not thrombolized.
I have a question. What sort of doses of DDAVP were you giving the patient?
So
like the minimal and then, yeah.
So I think on the endocrine ward, he was given one DDAVP nasal spray. That was the only time he was given it was when that sodium climbed. I think in ITU he was given like a quarter of a tablet, 25 micrograms, yeah. So very, very small doses, but he was very sensitive to that treatment.
Primi mentioned there were some questions on the chat. Did you want to?
So there's something about copeptin, about where it's measured, and if it's validated for this situation, where we have. And the other question is, why didn't we do a water deprivation test? That's our kind of standard way of diagnosing vasopressin insufficiency.
Yeah, I'm not sure.
He did it himself, did he? Yeah.
Plasma osmolality and he had normal the whole time. Yeah. That's 280.
May I just repeat that?
2 seconds, sorry.
Yeah, he had a normal plasma osmolality at 280.
Yeah, so before he went to Cambridge, he likely had AVP deficiency at that point, and he received desmopressin then. I don't think he needed a water deprivation test. The copeptin measurement was kind of analogous to doing a water deprivation test, because at that point he was polyuric and hypernatremic and not making much copeptin. So we think he definitely has AVP deficiency. The problem we had was the treatment was worse than just leaving him to, his body was smarter than us giving him any treatment.
2 seconds, there's a question at the back.
Yeah, just while we're waiting, so it could also be, of course, that his thirst was a bit affected by the stroke, and he may have not been able to drink, and then it goes up, and then when he can drink, it comes down.
Yeah. Do you think he could have recovered? Because, I mean, doing nothing seems to have been the safe response. So I think we quite often see this, that there's variability, and I also recognise that managing it in ITU, that they sometimes follow parameters in a way that can make it a little bit tighter both ways. But I think it seems to me that he may be normal now because he's not needing any treatment. I mean, unless you've got someone that's excessively drinking, you've got large volumes in and out. If he's just drinking normal amounts and peeing normally, then he's normal, isn't he? And if you've got any doubt that he's partial, it depends on his frailty and his comorbidities. And the other question I had was, actually, there are cases, aren't there, we see where it's a bit tricky to know whether to operate or not, especially in elderly people who may be difficult to assess their vision. And actually, sometimes watching and waiting is perfectly all right, because an apoplectic lesion may shrink in time and things may improve. But you have to really individualize your care, because assessing vision can be, it's easy to write it down as the next step in management, but the practical realities, there can be many factors why it's difficult.
I just have a quick question about this copeptin. Was it checked when he was in ITU? Yeah. So is it worth maybe repeating it? We can't measure it yet, but it was measured in our about the triphase response, but this feels like it's gone beyond that.
Oh, sorry. Yes, I'm standing here looking at you, Sage. I'm so sorry.
Sorry. So he definitely has had different phases. And going back to Emma's point, Emma Hatfield, that he was definitely AVP deficient. Then it looked like he had SIDH because he actually had a funny turn, which what sounded like a fit when his sodium dropped to 121 in neuro IT in Cambridge. And then they tried many times to see if he didn't need it. And each time he became polyuric, and we were watching him like a hawk. And his urine output was above 3 litres most days. But he was able to drink to thirst. And our worry was not just the medicine, but his family were very keen on hydrating him. So a lot of the treatment was, yes, he could be back to normal, but what we suspect is following surgery, we didn't put a slide up, but his hormone deficiency was actually greater post-surgery. So pre-op, he had some FSH, some LH, some prolactin. Post-op, he had 0. So actually, we suspect he does have AVT deficiency, but he's just very, very sensitive, and he's just fine by himself. We were worried about giving him DDAVP to take home in case he took it inappropriately, if he got confused. He was 79, and that was the big thing about whether surgery would be helpful for him, because and that's another thing, we don't even know if the surgery helped his vision because it was so hard to assess pre-operatively. So he felt it was better, but that could just be that he was better.
Thank you.
Jeremy.
Jeremy.
Sorry, I'm Jeremy Cox from St Mary's. I just wanted to make a comment that one of the reasons it's very difficult to predict is solute load. So let's just say I'm 80 kilos and I eat 10 milliosmoles per kilogram a day. I have 800 milliosmoles to get rid of. If you're running your urine at 100 because you've got vasopressin deficiency, then you would have to pee out 8 liters to get rid of that solute load. So you also have to bear in mind what solute is the patient taking in? How much are they eating? Or are you giving them osmoles such as normal saline? Because they will be peeing that out. And most of these people are not in a sodium deficiency state. So if you give them sodium, then they will have to get rid of that, and that will generate a huge urine volume. So just to say, there's a second side to look into. In pediatrics, I think about a lot in this in sort of nephrogenic DI, but solute load's important.
Thank you. And I really loved your cycle, which I have definitely found myself in before, where the DDAVP wears off and you're trying to work out what is going on. Is this person truly AVP deficient, or are you just seeing escape because the DDAVP is worn off in a normal individual? I've definitely had that recently, and it was tricky. So that was lovely to see, actually, because I really recognise the clinical situation there.
I think that's it, really. So thank you. On to the next speaker, Dr. Mahmood. The delayed diagnosis of pituitary adenoma in a patient with hypereosinophilic syndrome and a new diagnosis of myasthenia gravis. It's a combined presentation, is it?
Yeah, that's the one.
Okay.
Hello, my name is Rohan, and me and my colleague Bashir were both SHOs in Queen's Hospital, and we're going to do this presentation of quite an interesting case. Okay. Okay, so our patient is a 54-year-old man. His medical background included asthma, hypertension, and a disorder which many may not be familiar with called hypereosinophilic syndrome. So this is a syndrome in which it's a hematological condition in which there's a abnormal buildup of eosinophils as well as infiltration of tissues. It's a multisystemic disorder. It affects different tissues. The most common sites are usually skin, the GI tract, and the lungs. So in our patient specifically, it involved his GI tract. His common presentations would be diarrhea, and he was on steroids for that. He also had some skin symptoms with the chronic urticaria. So he came into A&E. He presented previously just well. He presented with a 3-day history of a left drooping eyelid and double vision for about 2 days. Otherwise, he had some headaches on and off, but he didn't have any other symptoms. He didn't have any weakness. He was seen initially by the stroke team, and the stroke was ruled out. He was later on examined and found just to have left eye ptosis. He didn't have any visual field loss. On the examination, he also had an ECG with a new left bundle branch and a type 2 block, which was a new finding. He was quite bradycardic with it. In terms of his social history, he was fully independent. His drug history of note was he was on PRED, 4 to 9 milligrams, and he had been at this dose for more than 10 years. He was allergic to fish and seafood, and his daughter, incidentally, was found to also have a pituitary adenoma, not symptomatic. So he had an CT scan done on admission, which showed a bulky pituitary. So based on that, the initial diagnosis was of a third nerve palsy due to a pituitary adenoma. This is an ECG just showing the type 2 heart block. And then he later on had an MRI. So the MRI was reported as a pituitary macroadenoma with only minor optic nerve optic chiasma compression. So then these are the lab results from specifically his hormonal profile. So it shows low testosterone with abnormally normal LH and FSH. It shows a low T3 and T4 but normal TSH, which was secondary hypothyroidism. He also had a low cortisol, but he was on long-term steroids. So he was discussed in a neuroradiology MDT. They felt that the tumor wasn't really enough to explain this ptosis that he had. They did a new examination. So they found that he had left ptosis with fatigability. It was much worse in the mornings. I mean, it was much better in the mornings, and it was better with rest. They didn't find any pupil involvement. He had mild diplopia. They did an ICE test, which is a test where an ice pack is placed on the eye and it immediately improves the ptosis. So that was positive. So their working diagnosis at that point was myasthenia gravis. So he had some tests done, which some of these were done later on, but it was confirmed based on the ACH antibodies. So I think now we should continue.
So at this point, the working diagnosis for him was triple, in the sense that they thought it was ocular myasthenia gravis. He had the heart block, 2-to-1 heart block, and there was this incidental non-functioning pituitary macroadenoma with subsequent hyperpit. So the neurology team wanted to start him on pyridostigmine. However, due to his bradycardia, they wanted him to have a pacemaker put in, as the risk of complete heart block was significant with this patient. He was also started on levothyroxine and testosterone replacement, and was discharged with neurosurgical outpatient follow-up for the pituitary adenoma. 2 years following that presentation, he came back to us with deterioration in his vision. He had a subsequent MRI which showed that the adenoma, the initial MRI showed that the adenoma was 16 millimeters, and when he came back 2 years later, it had significantly increased to 26, and there was suprasellar and sellar involvement. The suprasellar was actually going up and obstructing the optic chiasma, as seen here. Yeah. And there was also cavernous sinus spreading of the adenoma. He had a transsphenoidal surgery as a result of this presentation, for which they removed the majority of the tumor. However, there was a 3 millimeter residual tumor that was left behind post-surgery. And this, which appears to look like a tumor itself, is actually post-operative fluid collection. Post-surgery, the pituitary adenoma, which was removed, was sent to the histopathology lab, and it showed that the adenoma had a mild and focal immunoreactivity for FSH and LH, in keeping with a silent gonadotroph adenoma. He also developed AVP deficiency post-surgery and was started on desmopressin. Currently, he's on the desmopressin, the levothyroxine, and the testosterone. He continues to be on the high dose of steroids for the hypereosinophilic syndrome. And he is also still on the pyridoxine for the myasthenia gravis. This is just to show the result of the desmopressin, the AVP deficiency, the diagnosis of it. Sorry, I'm not sure if you can all see it.
Yeah, we can.
Yeah.
Let's go through it.
Yeah. So I think I think we did a desmopressin suppression test and it increased here. And then that's why he was started on the desmopressin at this point. So our question for the panel we have 4 questions. The first one is, did the long-term steroid management for his hypereosinic syndrome delay the presentation and diagnosis of the hyperpit and the pituitary adenoma? Did the progression of the adenoma, was it slowed by the high dose of steroid use? If the adenoma does reoccur, this is for our surgeons around, would it be advisable for resection? And lastly, because of the familial component to the pituitary adenoma, with the daughter also having it, would FIBA testing, genetic testing, would that be something we should consider? Thank you very much.
Thank you.
Thank you very much. That's lots of difficult questions. Is there anyone that would like to comment? I think for me, the long-term steroids definitely, I mean, we have all seen cases when patients were on steroids and that delayed the diagnosis. So I think delayed the diagnosis, not the presentation, possibly. I would say that that's the more of a...
And it's probably not been harmful, has it? Because otherwise you'd had a crisis, potentially.
Yeah, to prevent the crisis, yeah.
Potentially. Could his pituitary involvement be related to the hypereosinophilic syndrome is a question. I think we don't know. It might just be incidental. But it was a non-functioning, wasn't it? I mean, that's a typical non-functioning pituitary tumor that we see.
And the ptosis was unrelated to the tumor, clearly. The myasthenia gravis was well established.
Yeah, it was well established by the neurology team. Yeah. They did
and also
loads of tests.
You wouldn't expect a non-functioning tumor without a hemorrhage to cause an acute turnover in any case. But in terms of your question about the surgery, if the tumor recurs, it depends whether it's going to cause any visual.
It has that 3 millimeter.
Yeah, the small residual there. It's quite tiny. We wouldn't go back in now, but I think we keep an eye on it.
Yeah.
There's no indication to go back in now, but maybe in future if it comes back, and one might think of going back in.
Okay. And regarding the genetic testing, because of the familial component, does anyone have any idea about that?
But what you do nowadays is you log into the system and you type in exactly what's happened. Okay, this is what happens, and you say the daughter had a pituitary adenoma, and it will say not indicated. Okay, or indicated if it's fulfills certain criteria. You need a number of them. And pituitary adenoma is incidentally found. 20% of us have a pituitary tumor, just to start off with. So I think the answer will be no to that, but I would always use the genetic screen. It's much better. You used to have to think about what you had to do, but now you just tell it the clinical scenario and it will do all the tests in one go. So it's a much better system if we can all use it.
And most of the time the answer is no, not needed. Yeah.
Thank you very much.
Now there is a comment, and I also thought about this. There's 2 questions. Did he have a thymoma?
Sorry, did he have a
thymoma? You know,
I can't remember reading about a murmur.
Do you want to just go back to the water depth test, because it was a little bit odd. The start of the 9 o'clock unit osmolar is really quite high, which looks like, is this patient? He looks like he's on his vasopressin.
No, he wasn't on the vasopressin.
Because at 9 o'clock it should be a bit more dilute than that. So it's not quite as we'd expect. But I can't explain it really. Yeah, it's not.
But he wasn't
really,
on anything prior to the testing.
It's not really in keeping with vasopressin insufficiency.
Yeah, this was when it was administered at 3 o'clock. Yeah.
I can't explain that result actually.
He was on high dose steroids for the.
Okay.
Okay.
You have a question as well here?
It might be a very far-fetched question, but myasthenia gravis can be part of paraneoplastic syndromes. And not that I'm aware of that pituitary could cause any of those things, but is there any association? Because we're looking for genetic causes or paraneoplastic stuff.
The honest answer to this question is we don't know. But we're happy to go and ask the neurology colleagues when we do go back to the hospital. Because from what we've read, there was no investigation of a paraneoplastic. Yeah, sorry.
So we don't think there's a malignancy.
He's had a bone marrow biopsy.
I think we're stuck with more than one diagnosis, aren't we? In the end, it's not going to. We're not going to be able to unify this all in one go.
Anything on the Zoom? No.
No, I think that's all.
Okay.
Very interesting case.
Thank you.
Thank you for using the term. We're slowly getting better at using these terms. Oh, Gideon's got his hand up. I don't know if do you want to try and say something, Gideon? I can see. No, I think we can't. Hang on. Let me see.
No, I just want to add.
Sound
I think
on
from
here.
Can you hear me?
I'll have a go, okay? Just have a go at saying something.
Can you hear me?
Oh, I see. Try again.
Can you hear me?
Weak. I'm going to try different loudspeakers until you can hear me. No, I'm afraid, I'm really sorry about this, but let's try the last one. Try and say something now, Gideon.
Yes. Can you hear me? Good morning.
Yeah, we can.
I just wanted to add to the question of saying that whether that was a paraneoplastic or not. I think this was established ocular myasthenia, and there was no evidence of malignance with him. And I think the neurology team were very happy with the diagnosis of ocular myasthenia. And the other diagnosis came after that.
Great. Okay, thank you for that. That's a good summary. Okay.
Are we done?
I think we are a bit early.
Are you want to announce the lunch?
We're ready for lunch.
We are ready for lunch.
Okay.
Okay, thank you very much. For those of you remotely, please do have a break, and we'll be back for the afternoon session at 2:10. Thank you very much.